If you get diagnosed with lichen sclerosus, your first thought is usually, a sudden spike of panic.
Right, it's completely overwhelming.
Yeah, you instantly wonder, did I pass this to my kids? Or maybe did I inherit this from my parents?
It's a completely natural reaction. I mean, you're dealing with a chronic inflammatory condition that just fundamentally alters your skin.
Exactly. But when you actually look at the clinical data, the answer to that fear is this massive contradiction. Because 90% of the time, the people dealing with this intense itching, the soreness, and those distinct crinkled skin patches,
They have absolutely zero family history of the disease.
right, zero,
And yet, we classify it as having a genetic component.
which is wild.
Yeah, the medical guidelines are very clear that genetics play a vital role,
Hmm.
which, creates a really confusing narrative for anyone trying to trace their own family tree.
So today, welcome to the deep dive. We're taking a stack of medical guidelines, peer-reviewed research papers, and patient clinic notes to basically solve this biological mystery.
We really need to track the genetic footprints of lichen sclerosus.
Exactly. From the statistical reality of what actually runs in families down to the specific microscopic glue in your skin that your own body is trying to destroy.
And we need to figure out why a disease driven by your DNA so rarely shows up in your relatives.
So to start, I think the best place to untangle that is with the actual familial rates, right?
Definitely.
Yeah.
Because the gap between the patient fear and the statistical reality is just huge.
Right.
The clinical data shows that familial rates for lichen sclerosus range from about 5.4% to 12%.
Okay.
So in the medical community, we usually just shorthand that to a 10% familial rate.
Okay, let's unpack this for a second because I really struggle with that label.
How so?
Well, if we are looking at a 10% familial rate, meaning 90% of cases are essentially isolated incidents within a family line, calling it a genetic disease feels like a stretch,
I get that, yeah.
It makes it sound like cystic fibrosis or Huntington's, where you inherit the mutated gene and boom, the outcome is locked in.
Right, and the terminology definitely trips people up there.
Yeah.
Because we are so conditioned to think of genetics as a direct Mendelian inheritance.
Like eye color.
Exactly. You get the blue eye gene, you get blue eyes.
Yeah.
But we are dealing with a complex inflammatory condition here, which means we're looking at a genetic predisposition.
Ah, okay.
You aren't inheriting a broken gene that guarantees lichen sclerosus. You are inheriting a shifted baseline of risk.
A shifted baseline meaning like your immune system is just hovering closer to the edge than the average person.
Precisely. It's a susceptibility.
Mm.
Your biological threshold for developing the disease is just lower.
Right.
The genes involved, they don't create the disease on their own. They simply create an environment where the disease is much easier to trigger.
Well, if we know the baseline is shifted, the researchers must have identified the specific genetic suspects shifting it, right?
They have, yes.
Because the sources we reviewed point heavily to the HLA system, the human leukocyte antigen system.
That's the one.
I see these alphanumeric codes everywhere in the literature. Things like HLA, DQ7, DQ8, DQ9, DR12.
Yeah, they're a mouthful.
I know these basically act as molecular identification tags for the immune system, but how do they actually malfunction to create this susceptibility?
Well, to understand the malfunction, you have to look at what those HLA class II antigens do on a good day.
Okay, so normally.
Normally, their job is to pick up fragments of proteins from inside your body, carry them to the surface of the cell, and present them to your immune system's T cells.
So they're showing off what's inside.
Right. They are essentially saying, hey, here's a sample of what's going on in here. Is this a normal skin protein, or is this a virus we need to attack?
So it's like the immune system has a fleet of bouncers at the door of a nightclub, checking IDs.
I like that. Let's modify that a bit, though.
Okay.
It's more like you have a fleet of bouncers who are incredibly proactive, but some of them have slight face blindness.
Oh, wow.
Yeah. The variants you mentioned, DQ7, DQ8, and DR12, are the bouncers who tend to misread the IDs of your own healthy tissue.
So inheriting the DQ7 variant means your bouncers are a bit jumpy and might throw out perfectly good patrons.
Exactly. When a patient carries that HLA DQ7 variant, for instance, their immune system is highly primed to look at a normal structural protein in the skin and suddenly flag it as a dangerous invader.
That's terrifying. And the numbers back up how aggressive these specific bouncers are, right?
Very much so.
Because in one study of children with vulvar lichen sclerosus, that DQ7 variant was present in like 66% of the cases.
Yeah, and in the control group, it was only 31%.
That's a massive difference.
The concentration of those specific variants in the patient population is just undeniable. But, the HLA system also shows us the flip side of the coin.
The flip side.
Yeah, carrying the HLA-DR17 variant actually appears to have a protective role.
Oh, interesting. So that's the cooler, calmer bouncer.
Exactly. If you have the DR17 variant, your bouncers are remarkably good at their jobs. They keep the peace and actively suppress that autoimmune misidentification.
There was one study that really caught my eye regarding how these genes don't just trigger the disease, but actually dictate its severity.
Oh, the Chinese population study.
Yes, the Han Chinese population study.
Hmm.
It found that women carrying HLA, A11, B15, B35, and DRB112 genotypes weren't just more susceptible to vulvar LS.
Right.
They were specifically more susceptible to developing squamous cell carcinoma down the line.
Yeah.
But why would an immune system tag lead to a malignancy?
Well, that is where the pathology gets incredibly complex. Malignancy in lichen sclerosus is generally driven by chronic, unchecked inflammation.
So the tissue is constantly under attack.
Right. It's constantly being damaged and forced into hyper-repair, which naturally increases the chance of cellular mutation.
Okay, that makes sense.
Now, if you carry those specific HLA variants from that study, your immune system might be particularly bad at recognizing and clearing out those newly mutated dysplastic cells.
Wow. So you have the chronic inflammation creating the fire and a genetic blind spot allowing the precancerous cells to hide in the smoke.
That's a perfect way to put it, yeah.
Which really highlights that these HLA genes aren't just localized to the skin of the anogenital region. They are systemic.
Absolutely.
The immune system is patrolling the entire body with these face-blind bouncers.
And that systemic nature completely changes what you should be looking for when you examine your family history.
Right, because we tend to just look for the one disease.
Exactly. But lichen sclerosus is fundamentally an autoimmune-mediated condition. The specific genetic legacy being passed down isn't necessarily a targeted attack on the vulva or the foreskin.
It's just immune dysregulation in general.
Right.
The statistics on this are staggering, honestly. Did you see the part where 20% of lichen sclerosus patients have a second autoimmune disease themselves?
Yes. And 22% of their family members have one too.
That's almost a quarter of the family.
The genes cluster, but the resulting diseases diverge. So we see a very specific cluster of sister diseases that share this same genetic root system. Thyroid disorders really dominate this space. Over 44% of women with lichen sclerosus have thyroid autoantibodies.
Wait, really? Nearly half the patient population is walking around with their immune system also taking aim at their thyroid.
Yeah, it's incredibly common.
Yeah.
And beyond the thyroid, the cluster frequently includes vitiligo, pernicious anemia, alopecia areata, and type 1 diabetes.
So if you are looking at your family tree right now, trying to assess your kid's risk or figure out where this came from, you shouldn't just be looking for lichen sclerosus.
No, you'd be missing the forest for the trees.
You should be looking for autoimmune conditions in general. You might have LS, but your mom might have Hashimoto's thyroiditis, your uncle might have type 1 diabetes, and your sister might have vitiligo.
Exactly. The genetic thread connecting all of those is the tendency to produce autoantibodies.
Okay, but if it's a systemic tendency, why does it target those specific areas, like the anogenital skin?
That's the big question.
The sources zoom in on a very specific microscopic target that ties this whole genetic mystery together. And I really want to dive into what the immune system is actually destroying here.
Let's do it. The target is a protein called extracellular matrix protein 1, or ECM1.
ECM1.
Yeah, it's a glycoprotein that serves a crucial structural role.
I saw it described in the papers as the biological glue, or like the mortar holding the skin together.
Mortar is a very accurate way to think about it.
Oh.
ECM1 holds the bricks of your skin's basement membrane together.
Okay.
It regulates collagen fibril assembly. It helps maintain the integrity of blood vessel walls and the dermis, and it essentially just gives the skin its structural resilience.
And in lichen sclerosus, the immune system decides this mortar is a threat.
Yes.
Because between 74 and 80% of patients have circulating IgG autoantibodies in their bloodstream that are specifically designed to attack ECM1.
The body is actively dissolving its own structural foundation.
That is brutal.
It is. And to truly understand the genetics of this mechanism, the clinical literature heavily contrasts lichen sclerosus with a very rare, entirely genetic disease called lipoid proteinosis. or LP.
Yes. The comparison between those two really helped me grasp the difference between inherited mutations and autoimmune attacks.
How so?
Well, with lipoid-proteinosis, you inherit a direct loss-of-function mutation in the ECM1 gene itself, right?
You're right.
So you basically inherit the biological instructions to make defective mortar.
Right. If you inherit that mutated gene from both parents, your body simply cannot synthesize functional ECM1 protein from day one.
But with lichen sclerosus, your body makes perfect mortar. The instructions are fine,
Perfectly fine.
but you inherit an immune system that sends out a wrecking crew to destroy it, the face-blind bouncers.
Exactly. That contrast is vital.
Mhm.
One is a structural genetic flaw baked in from birth, and the other is an acquired autoimmune attack, driven by genetic susceptibility.
And what's even more fascinating is how the microscopic damage manifests.
Oh, yeah. Whether the mortar is built wrong from the start or destroyed by a wrecking crew decades later, the visible damage to the skin looks incredibly similar.
Right, both cause severe hyperkeratosis and skin thickening.
But under a microscope, you can see the difference in how the tissue failed.
Which is so cool.
You can. In lipoid proteinosis, because the protein is defective everywhere, you see damage heavily concentrated around the skin's appendages.
Like the sweat glands.
Right, sweat glands and blood vessels. But in lichen sclerosus, because it's a targeted attack, you see this very specific band of hyalinization, a glassy, pale, scarred layer right below the epidermis where the immune system waged its war.
Wow. But this brings us to a massive contradiction in the timeline.
Okay, what's that?
Well, if I inherit these HLA variants, these jumpy bouncers,
What?
from the day I am born, why does the wrecking crew wait until I'm 8 years old or 55 years old to attack the skin?
That's a great point.
Or why might an identical twin with the exact same DNA never get the disease at all?
And this is the core of the two-hit model of disease. It moves us from pure genetics into epigenetics.
Okay, here's where it gets really interesting.
Genetics is just the loaded gun. Something in the environment has to pull the trigger.
Okay.
You can carry the HLA-DQ7 variant your entire life, but if the immune system is never provoked in that specific localized area, the disease remains completely dormant.
The triggers mentioned in the guidelines are surprisingly mundane things we encounter every day. Like, the most prominent physical trigger is the Koebner response.
The Koebner phenomenon is critical here. It's a process where friction, chronic trauma, or even a surgical incision causes the dormant autoimmune disease to flare up specifically in the damaged location.
So something as simple as tight clothing, horseback riding, or chronic rubbing can literally signal the immune system to start the attack.
Yes, exactly.
But how does friction pull a genetic trigger?
Well, when you subject the skin to chronic friction, you create microscopic tears in the tissue.
Ouch, okay.
Those damaged cells release distress signals, damage-associated molecular patterns, or DAMPs.
Okay.
This causes a rush of inflammatory cytokines to the area. Your immune system rushes in to heal the microtears, but because you have those face-blind HLA variants, once the immune cells arrive at the site, they become hyperfixated on the ECM1 protein exposed by the damage.
And the healing response turns into an autoimmune attack.
Exactly.
That is wild. The guidelines also highlight chronic exposure to urine as a trigger, right? Particularly in men with an uncircumcised penis or women experiencing minor incontinence.
Right. Urine is a significant chemical irritant. It causes localized oxidative stress, which alters the microenvironment of the skin.
So it's another trigger.
Just like the friction, this oxidative stress acts as a chemical alarm bell, drawing the immune system to the area where the genetic susceptibility just kind of takes over.
We also have to look at the bimodal peaks of this disease, pre-puberty and post-menopause.
The hormonal factor.
Yeah, because the most obvious common denominator between an 8-year-old girl and a 60-year-old woman is a low estrogen state.
The hormonal trigger is incredibly powerful. Estrogen is highly immunomodulatory.
Meaning it regulates the immune system.
Right. It supports the function of regulatory T cells, which act as the immune system's brakes. They keep rogue inflammatory responses in check. It also promotes a healthy skin barrier.
So when estrogen drops, the brakes come off.
The environment becomes far more permissive for a specific Th1 immune response to thrive. The loss of estrogen acts as the second hit that turns the genetic potential into active aggressive tissue destruction.
Man. And the research papers also brought up the role of microRNA 155. It feels like this is the mechanism that turns the attack into permanent damage.
It really is. MicroRNAs function like volume knobs for your genes.
Okay.
In tissue affected by lichen sclerosus, microRNA 155 is significantly overexpressed. It essentially turns the volume up to maximum on fibroblast proliferation.
Fibroblasts being the cells that generate scar tissue, right?
Right. So the immune system attacks the ECM1, destroying the mortar. The tissue is damaged.
Yeah.
Then microRNA 155 forces the local fibroblasts to aggressively over-repair that damage, laying down dense, tight sclerotic collagen.
Oh, wow.
That is why the skin loses its elasticity and eventually fuses or scars over.
This completely reframes how someone should view their diagnosis.
How so?
Well, if epigenetics shows us that our environment dictates how our genes are expressed, then managing those triggers like avoiding chronic friction, addressing incontinence, or treating hormonal imbalances isn't just symptom management.
Right.
It means even if you have the genetic predisposition, avoiding those things is actively keeping your finger off the genetic trash. You could potentially keep the alarm from going off.
Exactly. It is preventative medicine at a cellular level. You are attempting to keep the local microenvironment calm so the immune system never receives the signal to attack.
Okay, so let's bring all this complex biology, the HLA variants, the ECM1 destruction, the Kubner response, let's bring it back down to earth for the person listening right now.
Sure. So what does this all mean? What should they actually do with this information regarding their own family?
Well, the immediate reaction is usually a desire to warn everyone or, panic about the kids.
Of course.
But we have to return to that initial statistic we talked about, 5 to 12%.
Right.
A familial rate of 10% means there is a 90% chance your child or sibling will never develop the condition. Transmission is the exception, not the rule.
That's a huge relief. But the knowledge is still power. So how do you communicate this to your family without turning it into a terrifying genetics lecture?
You frame it around awareness, not inevitability.
Okay.
You can calmly explain that your diagnosis means the family might have a slightly higher baseline for autoimmune skin issues.
Just giving them a heads up.
Right. You suggest they simply keep an eye out for unexplainable itching, persistent soreness, or white skin changes.
Because catching this early completely changes the trajectory of the disease. It isn't just about stopping the itch. Early detection is paramount. When we catch lichen sclerosus, early, long-term, consistent treatment with ultra-potent topical corticosteroids like clobetasol is highly effective.
It stops the damage.
It doesn't just soothe the inflammation, no. It halts the architectural scarring and prevents the anatomical changes.
And it directly addresses that cancer risk we talked about earlier, right?
Yes. Consistent steroid use fundamentally suppresses that localized immune response, which mitigates the 5% risk of developing squamous cell carcinoma.
That's incredible.
You are shutting down the chronic inflammation that leads to cellular mutation.
So just like you would tell your family about a history of diabetes or heart disease to encourage them to get blood work or early screening, you can do the exact same thing for LS without instilling panic.
Exactly. You're giving them the tools to advocate for themselves and seek early intervention if symptoms ever do pop up.
It transforms a genetic risk from a source of anxiety into a proactive health strategy.
It really does.
So we've tracked the footprint. Lichen sclerosus does have a genetic autoimmune root tied to the HLA system that can run in families, often branching out into other conditions like thyroid disease.
Yep.
But it is a predisposition. It's a shifted baseline. It requires an environmental trigger like physical trauma, chemical irritation, or hormonal drops to activate those genes and unleash the immune system on your skin's structural mortar.
Well summarized.
Yeah.
And most of your relatives will carry the genetics without ever pulling the trigger. Looking at all this data on how physical triggers alter the cellular microenvironment, it really makes you wonder about the non-physical triggers.
What do you mean?
Well, we know that the physical fiction of the Kubner response releases cytokines that pull the trigger on this genetic gun.
Right.
But could severe chronic stress do the exact same thing?
Oh, wow.
If cortisol and psychological trauma fundamentally alter our immune system over years, could the mind act as the epigenetic switch that turns on these dormant autoimmune conditions?
That is a staggering thought. If our internal environment, our stress, our trauma, can dictate the expression of our DNA, it really blurs the line between what we inherit and what we experience. If our environment dictates our genetics, how much power do we actually have over our DNA?
It's definitely something to think about.
Absolutely. Thank you so much for exploring this genetic landscape with us today on the Deep Dive. And to you listening, keep learning, keep questioning, and we will catch you next time.